Hello and warm welcome to MedSynapse channel, where we bring you insightful conversation with leading experts in medical field. Hi, I'm your host Dr. Smarika Bhatt, and today I'm honored to welcome Dr. Abhijit Powar to the platform, a distinguished healthcare professional with extensive experience in gastroenterology and oncology. Dr. Powar is Chief Consultant at Saraswati Surgical Hospital, Kolhapur, Maharashtra. In today's episode, Dr. Powar will be sharing valuable insights on the early detection of esophageal cancer.
Hi, my name is Dr. Abhijit Powar. I am an advanced GI Endoscopist and minimal access surgeon. So today we are going to talk regarding the early esophageal cancer and its management, diagnosis part, and surveillance and screening regarding the early esophageal cancers. So we start our discussion with a small case. So 63-year-old female, known case of hypertension, came with the chief complaints of retrosternal burning sensation, fullness of abdomen, associated with the mild discomfort since last 6 months. History of patient's son died of GI cancer few years back. Details are not available. No history of dysphagia, fatigue, hematemesis or melena. No history of any addiction. No history of significant weight loss or loss of appetite. On general examination, patient is conscious, well oriented about time, place, person. BMI is 26. Vitals are stable. No jaundice, edema, lymphadenopathy at present. On systemic examination, abdomen is soft. There were mild epigastric tenderness present. Cardiovascular, central nervous system and respiratory system examinations all are normal. Biochemical test, on performing the complete hemogram, there was a microcytic hypochromic anemia with mild anisocytosis and few pencil cells. Stool examination shows hookworm infestations. RFTs and LFTs are normal. For further detailed evaluation, we performed ultrasonography of abdomen, which is normal, and esophagus. So next we plan upper GI endoscopy. And on performing the upper GI endoscopy, there was a long segment circumferential, flat, slightly irregular, 6 cm mucosal patch with area of clear demarcation seen in mid-esophagus, which is extending 28 to 34 cm from the incisors, and from that suspicious patchy lesion, biopsy is taken for the confirmation. So these are the upper GI endoscopic images of the mid-esophageal patchy lesion, which shows some disintegrated intra-papillary capillary loops. So on NBI, magnification NBI, the lesion showed abnormal intra-epithelial papillary capillary loops, and the pattern is type 4 according to Inau classification. For detailed examination regarding this patchy lesion, we performed a chromoendoscopy by application of Lugol solution, and the entire normal esophageal squamous epithelium takes the uniform uptake of the Lugol solution. So it is diffusely showing a uniform uptake in some part, and other part there is a uptake is reduced. So the malignant cells which are having less glycogen shows decreased uptake, and this area which is showing decreased uptake can be intensified, and from that area we can take biopsy also. So this is a suspicious area, and we going to perform the biopsy there, and we confirm the diagnosis. So now we start with the discussion regarding the early esophageal cancer, and the case which we talked earlier is biopsy report came to be high grade esophageal neoplasia, and we performed for that patient we performed the ESD. So from introduction point of view, so what is the definition of early esophageal cancer? As per Japanese classification, early esophageal cancers are T1A cancers are the cancers which is involving the esophageal mucosa, and T1B cancers are the cancers involving the esophageal submucosa. And T1A and T1B lesions does not have lymph node metastasis. So what is the importance of early detection? So esophageal cancers having poor prognosis. Exceptions to these are early esophageal cancers, but challenges lies in the diagnosis. According to stage and 5-year disease specific survival, if T1 lesion is diagnosed, then survival 5-year survival rate will be more than 80%. For T2 and T3 lesions, the survival going to be reduced to 45%. And if the distant metastasis is there, then the survival will be reduced to only 4.8%. So esophageal cancers is an aggressive disease due to biological nature and anatomical features that readily promote the loco-regional and distant spread, such as, and this is all because of the extensive lymphatic networks in and around the esophagus. The 5-year overall survival rate is less than 20% in case of cancer, esophageal cancers. Thus, there is a dire need of effective screening strategies to diagnose it earlier. What is the epidemiology? As per WHO Globocon 2018 survey, the esophageal cancer ranks 7th among the most common cancers, and it is 3.2% in incidence in the world. It is the sixth most common cancer in India, with an incidence of 5.04%. As per population-based cancer registry in India, cancer of the esophagus is leading sites in the registries in the states of Assam, Meghalaya, Mizoram and Nagaland. These northeast regions of the India came under esophageal cancer belt, and which extends from northeast China to Middle East China. So in Assam, there is one cultural habit is there for making a food called kalakhar, which is alkaline in nature, and it is commonly used. The study over there performed in the Guwahati Medical College shows that the kalakhar intake more than 2 to 3 times per week leads to the increased risk of the esophageal cancers. So it is basically the behavioral and cultural food habits that makes the difference over there, and we'll going to talk in next few slides regarding the further details about the esophageal cancer. So in epidemiology, the squamous cell carcinoma is the predominant histological type worldwide. High incidence in the Asian belts, which includes Turkey, Iran, Kazakhstan and China. And esophageal adenocarcinoma is going to be increased in the Australia, USA, UK and some Western European countries. The prevalence of the esophageal adenocarcinoma is increasing in some Asian countries such as Singapore. Male to female ratio, the global prevalence is 2.77:1 and prevalence in India is 3:1. The population-based case control study by Cronin and Fenton and co-workers has stated positive protective role of female hormones and breastfeeding, and in some other studies, predominance in male may be due to the exposure to different addictive substances like tobacco. Most patients with early stage esophageal carcinoma are over the age of 65 years. So what are the risk factors for the cancers? We start risk factors regarding the squamous cell cancers, and then we'll discuss regarding the adenocarcinoma risk factors. So first, squamous cell carcinoma risk factors are tobacco, smoking, alcohol consumption. In alcohol, the aldehyde metabolite which is going to be formed in the liver is basically a carcinogen. Mutation in the enzymes that metabolizes the alcohol may lead to the squamous cell carcinoma. Other risk factors include achalasia, acoustic injuries, poor oral health, head neck cancers, low socioeconomic status, nutritional deficiencies that may lead to the antioxidant deficiency in the diet. Rare causes includes the non-epidermolysis, palmoplantar keratoderma. Risk factors for the adenocarcinoma includes symptomatic gastroesophageal reflux disease. It is the strongest risk factor. Barrett's esophagus, the risk has been estimated to be 0.5% to as low as 0.12% in some studies per year. central obesity, history of thoracic radiation, consumption of burning hot beverages that leads to formation of reactive nitrogen species, and that leads to the mutation in the tumor suppression gene T53 gene. There is also risk for adenocarcinoma in the patients who are consuming high pickled vegetable intake. The pickled vegetable intake leads to the fermentation. Pickling process leads to the fermentation, and fermentation leads to the formation of the high nitrosamine compounds which are carcinogenic. Rare diseases include the esophageal lichen planus tylosis. So what is the pathophysiology of these cancers? Squamous cell carcinoma and adenocarcinoma are the most histological types that we have discussed earlier. The rare pathologies includes adenoid cystic, mucoepidermoid, adenosquamous, small cell carcinoma, sarcoma, melanoma, and lymphoma. Chronic inflammation is thought to be the precipitating factor in both squamous and adenocarcinoma. In squamous cell carcinoma, the chronic inflammation precipitated by the toxins such as toxins including cigarettes, alcohol, and aflatoxins are the main factors. In adenocarcinoma, the chronic inflammation precipitated by the acid bile reflux into the distal esophagus and other factors such as dietary nitrates contribute to the progression to the cancers. So this is the pictorial representation of the cancers, adenocarcinoma, squamous cell carcinoma, and there may be overlapping features which are common to both, and these all risk factors leads to a series of events which leads to the somatic mutations, and these mutations are propagated in terms of resistance to growth inhibitory signals, autonomous proliferation, avoidance of the apoptosis, unlimited replication, angiogenesis, and invasion and metastasis. That all leads to the mutated cells survival and clonal expansion, and these all going to final outcome should be the carcinoma. So what are the clinical presentation? Early esophageal cancers are often not apparent in its early stages. People may have following symptoms such as dysphagia, odynophagia, indigestion, persistent heartburn over long period of time. Weight loss may not be commonly seen. Reduced appetite, regurgitation of the food from the esophagus, persistent hiccups, and chronic cough. These all symptoms are vague, and early esophageal cancer may not be present with these kinds of symptoms. So what is the diagnostic workup required for the early evaluation? That one of the most diagnostic workup includes gastroscopy. It identifies the microscopic features such as cancers, nodules, ulcers, strictures, or growth. It assesses the extent of the tumor, whether the tumor assesses whether the cardia, stomachs are involved in distal esophageal carcinoma, whether it assesses the proximal extent of the tumor and its relation to cricopharyngeus in proximal carcinoma esophagus. Gastroscopy can identify the need of an additional intervention in patients with severe stricture. Careful dilatation may be required to assess the extent of the tumor. And limitation of this gastroscopy is only one, that unfortunately early cancers are often macroscopically normal as IPCL pattern barely recognizable under white light endoscopy. Optical chromoendoscopy or narrowband imaging, new tool in the endoscopy. So real-time optical chromoendoscopy is easy to use. Sharp demarcation of early neoplasia highlighting the dense vascular pattern can be seen properly under NBI. In combination with the magnification, clear distinction of IPCL disruption noted by experts, and it required adequate training and expertise to recognize this. So chromoendoscopy basically means endoscopy by applying special dyes to make the lesions more prominent or easily recognizable. So we use acetic acid for high-grade dysplasia to diagnosis of high-grade dysplasia or adenocarcinoma in previous Barrett's esophagus, and Lugol's 1% Lugol solution we use generally for the diagnosis of early squamous lesions. If the endoscopy is showing some suspicious malignancy, we have taken the biopsy. Then biopsy is the next line of investigation in diagnostic workup. In biopsy, inter-observer variations can affect the diagnostic accuracy of above methodologies, and thus biopsies of the suspicious mucosal lesions are taken for confirmation of the diagnosis and decide further treatment plans. There is a limited evidence for the optimal number of biopsies required to ensure diagnosis. The accepted convention is to obtain 6 to 8 biopsies of the lesion. So, immunohistochemistry, IHC staining is recommended in poorly differentiated and undifferentiated cancers when the differentiation between the squamous cell and adenocarcinoma using the morphological characteristics is not possible. This is as per guidelines of American Joint Committee on Cancer. In addition, other less frequently occurring tumor types such as neuroendocrine tumors, carcinomas, lymphomas, mesenchymal tumors, melanomas, or secondary tumors must be identified separately from squamous cell carcinoma and adenocarcinoma. The IHC studies will be helpful here. Multiple OJD biopsies can be fixed in formalin, and it do allow IHC study. It can inform the presence of certain biomarkers such as MCM2, cyclin A, PDL1, HER2/neu that can be used for future therapy, immunotherapy if need arises. So next diagnostic workup will be bronchoscopy with endobronchial ultrasound. It assesses the tumor growth towards the central airways. It is complementary to EUS, especially when the tumor stricture prevents the endoscopic ultrasound of the esophagus. For staging, accurate staging is paramount before proceeding with the endoscopy treatment. The TNM includes the tumor invasion depth, nodal status, and metastasis. It is done by tumor staging is done by endoscopic ultrasound. It assesses the depth of the tumor invasion and loco-regional lymph node spread. Endoscopic ultrasound assesses nodal status. Accuracy in node positive patient will be up to 84%, and accuracy of the EUS in node negative patients falls to around 69%. AG guidelines strongly against the routine use of EUS in early esophageal cancer to stage T1A and T1B diseases. So FDG PET, the primary use for detection of distant metastasis and for assessing the response to induction chemotherapy. It is not useful to establish tumor status, that is T stage of TNM. Accuracy in the assessment of the nodal status varies widely. It will be 27 to 90%, and it is vary according to person going to perform this PET CT. It is less useful in staging of early esophageal cancers. A study of 79 patients with clinically staged T1A and T1B esophageal adenocarcinoma who underwent preoperative PET CT showed all FDG avid nodes seen were false positive. This suggests the PET CT could lead to more unnecessary biopsies. Post endoscopic submucosal dissection, PET CT, if performed, if a tumor is found to be more advanced on pathology surgical specimen after ESD, PET CT has limited utility as inflammation of the resection bed is often FDG avid on the PET. For endoscopic assessment, before endoscopic resection, observe the peristalsis of the esophagus to assess the invasion depth of the lesion. Delineation of the early malignancy should be performed. If it is possible, then delineate the lesion using white light endoscopy or NBI. Classify the lesion by Paris classification. If the delineation is not possible or disease is diffuse, then endoscopic ablation can be used in patient with proven high-grade dysplasia with no visible lesions. For the endoscopic ablation, radiofrequency Nd:YAG laser or organ plasma coagulation can be used, but few studies have shown that radiofrequency ablation is more useful, more effective than Nd:YAG laser than APC. Japan Esophageal Society had advocated Paris O2 lesions with M1 M2 invasion and less than 2/3 circumferential extent as absolute indication for the endoscopic resection. So management of adenocarcinoma, endoscopic resection can be considered for tumors at low risk of lymph node metastasis and for tumors with high risk of lymph node metastasis but medically unfit for surgery. So who are the low risk or high risk patient of lymph node metastasis? So according to tumor extent, the patients can be categorized as low risk, high risk. If the adenocarcinoma tumor extend up to the mucosa, then lymph node metastasis risk will be 1 to 2%, which is the lowest. If the adenocarcinoma of esophagus extending up to upper 1/3, that is less than 500 micron of the thickness of the submucosa, then lymph node metastasis risk will be 7.5%. If it is involving middle third of the submucosa, then it is lymph node metastasis risk will be 10%. For deeper invasion, it will be 45%. So as the stage of the disease, T stage of the disease goes on increasing, the lymph node metastasis risk will be goes on increasing. There are two endoscopic resection techniques. One is endoscopic mucosal resection and other is endoscopic submucosal resection. EMR is safe, easy to perform. Success rates and procedural age of EMR have established it as a mainstay of treatment of early esophageal adenocarcinoma. In early esophageal adenocarcinoma, EMR will be sufficient, but in few subset of cases, ESD can be considered. Indication of EMR is generally lesions less than 15 mm are best for the EMR. Endoscopic submucosal dissection, facilitating en bloc resection and histopathologics assessment. It is recommended in the European Society of Gastrointestinal Endoscopy guidelines. Technically, it is challenging procedure having learning curve. En bloc resection rate is for this procedure is 83 to 100%. Complete resection rates are 70 to 100%. Local recurrence rate is going to vary from 0 to 2.6% in superficial squamous cell carcinoma. Indications for the ESD will be superficial tumors associated with the fibrosis, where the poor lifting will be seen in at the time of evaluating the lesion. After the injection of the submucosal injections, if the lesion is not going to be lifted, then it is called as it is considered as a poor lifted. For this, ESD will be better. And other indication will be for lesions involving more than 2/3 of the circumference of the esophagus. But in these cases, the risk of the esophageal stricture will be high. So curative resection. So what is the R0 resection? R0 resection means the microscopic margins of the tumor will be negative. So for esophageal adenocarcinoma, who are the patients who are considered to be R0 resection or complete resection? After ESD, if the subjective specimen shows well differentiated to moderate differentiated cancers, if the lesion is going to be invaded in SM1, but it is less than 500 micron meter, submucosal invasion will be present. And if the surgical margins are negative or lymphovascular invasion is negative, then all these esophageal adenocarcinoma considered as R0 resected surgical specimen. For squamous cell carcinoma, the resection histology shows well to moderate differentiated cancer, negative surgical margins and lymphovascular margins. Then it is considered R0 resection. Only difference is that in adenocarcinoma and squamous cell carcinoma, in submucosal invasion, adenocarcinoma extension is less than 500 micron meter. And for squamous cell carcinoma, if the extension is less than 200 micron meter submucosal invasion, then they are considered as R0 resection. So next line of management will be chemoradiation. Early esophageal adenocarcinoma T1A, T1B is the primarily managed with the endoscopic resection or surgery. However, recent evidences suggest that there may be a role of neoadjuvant or adjuvant chemoradiation in early diseases, particularly in patients with high-risk tumors. If the resection is incomplete resection, if the tumor has a deep extensions such as SM2, SM3 involvement, if the margins are positive, if the lymphovascular invasion is present, and if the tumors are poorly differentiated, then these are the patients who are candidates for the chemoradiation. Post-treatment surveillance includes, it is based on the post-resection pathologic staging, Barrett esophagus with high-grade dysplasia, Oesophageal performed every 6 months for 2 years and then yearly recommended. For T1A esophageal adenocarcinoma, surveillance consists of endoscopic ultrasound every 6 months for 2 years, then yearly, plus CT chest and abdomen yearly for 5 years. T1B lesions, surveillance includes endoscopic ultrasound every 3 months for the first year, followed by every 6 months for 1 year, and then yearly. Along with this, we have to perform the CT chest abdomen recommended every 6 months for the first year and yearly for the next 5 years. Screening the adenocarcinoma, current guidelines are, even though these are low quality evidences, allow screening of high risk populations. Those with long-standing gastroesophageal reflux disease, which is more than 5 years, those with frequent reflux symptoms, weekly or more, with 2 or more risk factors for the Barrett esophagus or esophageal adenocarcinoma. And these risk factors includes the male sex, age more than 50 years, central obesity, having waist circumference more than 102 centimeter or waist to hip ratio more than 0.9. Current or past history of smoking is the high risk category patient for the adenocarcinoma screening, and patient with first degree relatives of Barrett esophagus or esophageal adenocarcinoma or hiatal hernia. Patient diagnosed with Barrett esophagus without dysplasia should undergo endoscopy every 3 to 5 years. These are all the as per guidelines. Management of the early squamous cell cancers. So in squamous cell cancer, the lymph node metastasis risk is different, and for adenocarcinoma, lymph node metastasis risk is different. For this squamous cell carcinoma, if the tumor is involving to mucosa, M1, that is mucosa, or M2 is lamina propria extension, then the lymph node metastasis risk will be 0 to 3%. If the tumor extends up to M3, means it is involving the muscularis mucosae, then the lymph node metastasis risk will be 0 to 18%. If the tumor is extending up to the submucosa, SM1, or it is less than 200 micron meter, then metastasis risk will be 8 to 50%. So, based on this table, as the tumor progresses deeper and deeper, the chances of lymph node metastasis goes on increase. So, management of the early squamous cell cancers includes the high-grade tumors compared to basement membrane, that is confined to the epithelial layer. EMR can be performed. T1A lesions, tumor invades the lamina propria and or muscularis mucosa, that can be divided as per histological layers, M2 or M3. For the M2, the tumor involving the lamina propria, we can go ahead with the EMR. So basically M1 and M2 lesions, we can do EMR safely here. If the tumor is invading the muscularis mucosa and extending deep up to 200 micron meter in the submucosa, then these lesions are called T1B lesions, and ESD is sufficient for M3 and SM1 lesions. For SM2 and SM3 lesions, surgery or chemoradiation can be considered, as the lymph node metastasis risk goes on increasing for SM2 and SM3 lesions. So, screening of early esophageal squamous cell carcinoma there are no definitive guidelines for screening of these cancers. The majority, 90% of the relapses occur within first 2 years after completion of local therapy, that is endoscopic resection or chemoradiation, endoscopic ablation. Follow-up visits should be concentrated on symptoms, nutrition, and the psychological support. Screening for head neck cancer patient after 1 year after curative treatment is required. Surveillance for the early squamous cell carcinoma includes annual surveillance for all patients after curative treatment of early squamous cell cancers of the esophagus, and annual surveillance of all patients with low-grade dysplasia. So, chemoprevention means how can we avoid these cancers? So, various nutrients and minerals have been tested for preventive effects against the esophageal carcinoma, includes retinol, riboflavin, zinc, selenium, beta-carotene, and alpha-tocopherol, but none has yet shown notable preventive effects in the randomized controlled trials. Chemoprevention trials of black raspberries, which have high concentration of the nitrosamine inhibitor and selenium, are in progress. Retrospective data from multiple centers show that diet rich in antioxidants, fruits, vegetables, omega-3 fatty acids, polyunsaturated fats, and fibers are associated with the lower risk of the Barrett esophagus. So these are my references for this entire presentation. Thank you.
And thank you for your time and sharing your expertise with us. Your contribution to medical education and patient care continue to inspire the next generation of healthcare professionals. Thank you for dedicating your time and sharing your expertise with us. Your contribution to medical education and patient care outcomes is inspiring to the next generation. And thank you to our viewers for tuning in. And remember, if you are a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate us to join on MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers or participate in meaningful discussion and contribute to the ongoing evolution of healthcare. So until next time, stay tuned. Take care.